The Global Surgery Lab presents an approach to an open tracheostomy. The goals of this video are to identify indications and an approach for an open tracheostomy, and to outline key principles of post-operative management. Indications for an open tracheostomy are prolonged need for ventilatory support, semi-urgent for airway injuries with impending airway compromise. If you are in a controlled situation in the operating theater, an open tracheostomy is a better long-term definitive airway than a cricothyroidotomy. A contraindication to the procedure would be if the patient has an acute airway obstruction and is not spontaneously ventilating. In this case, the emergency procedure is a cricothyroidotomy, which is much quicker. Intraoperative complications to consider include bleeding from the branches of the anterior jugular veins or a thyroideima artery, which is present in 5% of patients. Another complication would be airway fire caused by the combustion of high oxygen concentration ignited by electrocautery. And finally, pneumothorax or pneumomediastinum caused by a false passage if the tracheostomy tube is placed anterior to the trachea. The general approach to performing an open tracheostomy includes 1. Palpate landmarks and make a midline incision. 2. Divide the tissue down to the trachea, including the thyroid. 3. Suture ligate the thyroid. 4. Make a tracheotomy incision. And finally, 5. Insert and secure the tracheostomy tube. For the procedure, you will need a scalpel, needle driver, sutures, small clamps, at least 2 Alice clamps, at least 2 self-retaining retractors, such as a Wheatlander, a tracheostomy tube, suction equipment, and cautery if available. In preparation for the procedure, if the patient is already endotracheally intubated, sedate and paralyze them. If you are doing a tracheostomy in a non-intubated patient, perform an awake sedation. Then, to begin, position the patient supine with the neck in extension. Place a shoulder roll behind the shoulder blades. To begin, properly prep and drape the patient. Landmark the sternal notch, cricoid cartilage and cricoid membrane, thyroid cartilage, and finally the location where you will make the tracheotomy incision. For this, you will want to go between the second and third or third and fourth rings of the trachea, which are usually very close to the sternal notch. Stabilize the trachea with your non-dominant hand and make a midline vertical incision, not demonstrated in this video, but cautery could also be used. Next, divide the subcutaneous tissues and split the strap muscles. You can insert your retractor. The layer separating you from the trachea is the thyroid. Since it is a well-vascularized organ, it is recommended to clamp it on the midline on either side of the isthmus. Divide it and ligate it. If cautery is not available, you may need to tie off the thyroid. There are a few ways that you can do this. A large single silk tie around each lobe, a running stitch, or a Blaylock stitch, which is a running horizontal suture in 2 layers. As previously mentioned, a small percentage of patients have a thyroideima artery, which must be identified and safely ligated. Make sure you expose the trachea well. Then count the rings by starting with the broad cricoid cartilage and counting down from there. Once you have selected the appropriate tracheal ring, clear the trachea for about 1/4 to 1/3 of its circumference. Do not go too far posterolaterally. Both recurrent laryngeal nerves are vulnerable to injury in this location. Adjust your retractors to keep the trachea exposed. Once the trachea is exposed, feel for the space between the 2 rings. Use the scalpel to mark a square, not cutting all the way through. Now, prepare the team by notifying them that you are going to make the tracheotomy incision. Grab the edges of the square with 1 Alice clamp and have more ready. Tell the anesthesia provider to pull back the endotracheal tube to avoid cutting the balloon. Then, complete the tracheotomy by cutting a full thickness square into the trachea. You will need to be quick with this step, as the patient now does not have a secure airway. Next, insert a cuffed tube, either a tracheostomy or endotracheal tube, into the tracheotomy incision you just made. It can be helpful to go in at 90 degrees to the orientation of the trachea, and then once you have the tip in, rotate 90 degrees to be well positioned into the trachea. Advance the tracheostomy tube fully into place and inflate the balloon. Remove the obturator and insert the inner cannula. The endotracheal tube can now be fully removed. Hold the tracheostomy tube secure and have an assistant attach it to the ventilator tubing. Proper positioning can be confirmed through end tidal CO2 or adequate tidal volume. Close the skin incision around the tube. Secure the tube to the skin with non-resorbable sutures. Attach securing ties to the plastic phalanges of the tracheostomy and around to the back of the patient's neck. Post-procedure, there are several things to watch out for. Acute obstruction of the tracheostomy tube may be caused by blood or mucus and is more likely in the immediate or early post-operative periods. Post-operative protocols involving scheduled flexible tracheal suctioning, use of humidified oxygen, and scheduled replacement or cleaning of the inner cannula daily can minimize the risk of complete obstruction. Tube dislodgement can result in acute obstruction if the distal tip of the tracheostomy tube exits the tracheal lumen and rests in the soft tissue or a false passage. Pressure necrosis due to overinflation of the cuff of the tracheostomy tube. Tracheostomy cuff pressure should be measured regularly to prevent this occurrence, ideally at a max of 20 centimeters H2O. High pressure in the trachea can lead to necrosis of the wall due to ischemia. An innominate artery bleed is a rare but lethal complication. The innominate artery usually traverses the trachea between the 6th and 9th cartilage rings. A fistulous connection between the trachea and the innominate artery can form, resulting in hemorrhage from the artery. And lastly, typically on removal of the tracheostomy tube, the stoma will usually close within 24 hours spontaneously. On occasion, granulation tissue formation leading to stomal stenosis can occur. In conclusion, an open tracheostomy can be used as a definitive airway in patients requiring prolonged ventilation or in patients with airway compromise who are still breathing spontaneously.